My name is Dorothy Meal. I'm the Head of College of Humanities and Social Science, and I'm absolutely delighted to be chairing the inaugural this afternoon. I'd like to extend a really warm welcome to everyone who's here, all Sharon's colleagues, students, and many visitors to the university and the city, particularly, of course, her own family, her mother, children and husband and in-laws and many other friends. You're all very, very welcome here this afternoon. It's lovely to be able to support Sharon in her inaugural, but also to help celebrate with her afterwards at a reception just outside. So I'd invite you all to stay afterwards and perhaps ask some of the questions that you'd like to ask of Sharon about her talk over drinks afterwards. I know that because there's such a mixed audience here, people who know Sharon from all sorts of different aspects of her personal and professional life, I thought it would be useful to just go over some of the highlights of her professional journey to her personal chair here at Edinburgh, to fill in some of the gaps for some of you who may not know all that she's achieved so far. So Sharon started studying psychology at the University of Reading, and she graduated from there with a first-class honours degree, and then moved on to investigate the neuropsychology of people with temporal lobe epilepsy, thanks to an MRC studentship with Professor Robin Morris at the Institute of Psychiatry. Once she'd successfully completed that PhD, she began researching cognitive and cerebral dysfunction in people with motor neurone disease. She was working on this in a postdoctoral position with Professor Nigel Lee and Laura Goldstein at the Institute of Psychiatry. In 1995, she won a Wellcome Trust Clinical Research Fellowship and trained with this as a clinical psychologist, and also furthered her work on motor neurone disease, in particular through the use of MRI brain imaging. In 2001, she then became a lecturer in neuropsychology at the Institute of Psychiatry, which is a part of King's College London. She moved here to the University of Edinburgh in 2004 and became a senior lecturer, joining the Human Cognitive Neuroscience Unit, headed by Professors Sergio Della Sala and Robert Logie here tonight. During this time, she established the master's degree in Human Cognitive Neuropsychology, and this continues to be one of the flagship programs for the college. She continued to work in neurodegenerative disease, and in particular in motor neurone disease, and was a founding member of the Ewan MacDonald Centre for MND Research, headed by Professor Siddharthan Chandran, who can't be here this evening, unfortunately. Her current post is one of those that is one of the very few split between the two colleges of Humanities and Social Science and Medicine and Veterinary Medicine. We try to do a lot to encourage interdisciplinary work at the university, and I think Sharon's work is an exemplar of this. And so one day a week she works as the lead clinical psychologist in the Anne Rowling Regenerative Neurology Clinic, where she runs a young onset dementia neuropsychology service together with Dr. Thomas Back. She was appointed to her personal chair of neuropsychology last August. Now, Sharon's research focuses on changes in cognition, social cognition, and behaviour in people with neurodegenerative diseases, and investigates corresponding brain changes using imaging techniques. Her work has contributed to demonstrating that mind really does matter in motor neurone disease, and that a large number of people will experience changes in cognition and behaviour in addition to the progressive physical disability. She and her colleagues have designed a quick and easy to administer screening measure to assess people in clinics, which is now being used across the world for research, clinical trials, and clinical management. The screening tool is sensitive to a wide range of cognitive changes and can identify the needs of that individual and help to provide appropriate support. Sharon leads one of the few research units of cognition in motor neurone disease in the world, involving experts in psychology, neurology, neuroimaging, neuroscience, and pathology, and involving not only those experts, but postdoctoral, doctoral and master's researchers as well. She also leads a large European research collaboration of cognitive screening in motor neurone disease, involving 15 major clinical centres right across Europe, with local translations of the new screening test produced at each site. This has recently expanded to include multi-centre initiatives in the USA, Canada and China. The international recognition of her expertise is also seen in her membership as the sole psychology representative of a range of international committees providing advice on cognitive and behavioural changes in motor neurone disease. Sharon's work is really exemplary in terms not only of her scientific achievements, but also her work with the Motor Neurone Disease Association and Motor Neurone Disease Scotland to produce guidance and publications on the issue for patients and healthcare professionals across the UK. I'm sure that we're all going to find her talk fascinating, and I'd now like to invite Professor Sharon Abrahams to present her inaugural lecture.
Okay, so I'm going to talk to you about, well, what is motor neurone disease first, so that we all know what we're talking about. And then I'm going to talk to you about why cognition is important in MND. And in particular, what I mean by cognition is changes in thinking and also behaviour. And then I'm going to tell you how we assess these changes. And finally, just a couple of slides on what difference it can make. So something about terminology first. Now, in the UK, we call it motor neurone disease, but this actually involves a range of diseases, quite similar diseases, but a range. The most common type is ALS, amyotrophic lateral sclerosis. But to confuse you all, in Europe and in the States, they just know the term ALS. They don't know the term MND. And often the two terms are used interchangeably. So generally, they mean the same thing. So I'm now going to show you what the public face of MND is. So first we have a picture here of Diane Pretty, and people may recognise her. Diane came to the public eye quite a few years ago as one of the first people to fight for assisted suicide. And unfortunately, this is one of the issues that does hit the public quite a lot with motor neurone disease, very sadly. I'm not going to go into that issue today. But just to recognise that this really is the public face of MND. Now, you might be a famous person already and then get the disease. So we have here Fernando Rickson from Rangers, a famous footballer, and Jimmy Johnson from Celtic. And as you can see, the disease knows no boundaries, affecting people across all sides. And as you can see here, even if you're very, very clever, you may get the disease. And obviously this person, who needs no introduction, is really phenomenal in many respects. This is also the public face of MND. I've put here some pictures of some truly inspirational people with the disease. Here we have Ewan MacDonald at the top here, and his father, and also Sudalsan Chandran. And Ewan and his father really have helped us to establish the centre that we have now here. You also see a picture of another truly inspirational person here, Gordon Aitken, and who has really improved our healthcare by fighting for increase of nursing provision in MND, and has succeeded in really increasing our nurse specialists in Scotland. Now, I've also put here, some people may recognise Sarah Ezekiel. Now, Sarah was actually the face of the MND campaign, advertising campaign that we had a few years back, and it was quite a controversial advert that came out. And one of the reasons, and Sarah is really truly inspirational of a person living with MND. And just to show you that it crosses no boundaries, Sarah is actually an old school friend of mine. So it can affect anyone, and it does, sadly. This is also the face of MND. As people may recognise this, the Ice Bucket Challenge, which was an outstanding fundraising scheme started by the American Association, and it gained a huge amount of money. We have here Ewan and our own MND team dropping water over their heads, and here's some famous people you may recognise. an ex-president. You probably wanted to do this to him for many years. I think he would have raised a lot of money. And here's Simon Cowell, obviously. But this is also now the public face of MND. Okay, so let's see what we're talking about now. As the name suggests, motor neurone disease is a disease of the motor neurons, and that is how it's diagnosed. So those are the neurons, those are the nerves that control our movements. Now, there are two types of motor neurons. We have the upper motor neurons, and they start off in the cortex here, the motor cortex, and they go down the spinal cord. And then you have some other neurons here, lower motor neurons, and they go from the spinal cord to the actual muscles. And with ALS, you get death of both of these two types of neurons. They produce slightly different symptoms. So when the lower motor neurons die, what you get is wasting of the muscles and fasciculations, little twitches in the muscle. And this is because these neurons are responsible for releasing all these trophic factors into the muscle. And you can see here on some of the clinical sides the wasting that you get in the small muscles around the hand. Now, the upper motor neurons control the activity of these lower motor neurons. So when these die, you get overactivity of the lower motor neurons, and you get spasticity and spasms. So you get this awful combination, and so you can see here the person's hands are beginning to claw. Now, the disease can begin in the arms, in the legs, or in the mouth, and the bulbar region, we call it. So it might start with people having maybe difficulty doing up their buttons, and then it progresses. It may progress to all of their arms, so they have really quite flaccid, useless arms. In some people, it can stop there for some time. The disease might begin in the legs, and people may notice a little foot drop, so they may start tripping. And then it can progress, and often a wheelchair is necessary. And if it begins in the bulbar region, those areas that control speech and swallowing, people may notice a little slurring of the speech at the beginning, or maybe that the food is sticking. Now, it's a horrific disease. There's no sunny side of that. And the disease can progress very quickly, and people can perish quickly from the disease. Okay. So why is cognition important in this disease? Well, when I first came into this area in the early 90s, really the disease was commonly thought to affect the system controlling movement only. And this is a disease which does not affect other brain functions involved in thinking and behaviour. And that was often taken as a saving grace by people suffering and by the associations, that the disease only affects my movement and my mind is still intact. Unfortunately, that isn't the case. And what we now know is that some patients have a dementia syndrome. In fact, we now know that about half of the people, the disease is restricted to those motor areas, and in about 15% suffer from this type of dementia called a frontotemporal type. And that's when you have this pathology which affects particularly the frontal lobes of the brain. Now, frontotemporal dementia actually occurs without MND. It's not uncommon. It's the second most common type of dementia for people under the age of 65, so the young onset dementias. And there are three types of frontotemporal dementia that occur. There's one called a behavioural variant, and that changes people's behaviour. And then there's two language variants. The type that we get in MND is particularly the behavioural variant. So what happens with this type of dementia is that you get a progressive personality change, a full behaviour change. Now, what has changed about the person? They may begin to show socially inappropriate behaviour. So this is, for example, they may become aggressive, or they may become sexually disinhibited, or just approach strangers, or maybe even have some criminal behaviour. So they're not following the social norms as we would. There may be a loss of manners or decorum. So people may start swearing or shouting, being a bit more rude. They may be impulsive. So this is when they can't delay, can't stop gratification. They have to do things immediately, there and then. And this combined with this loss of sympathy and empathy. So this is when people are not able to see another person's perspective. So they don't know what the impact of the behaviour is on the people around them. Now, as you can see, with just these two types of symptom, you have a personality change. And what is often reported by carers is that they're not the same person. This is not the person that I married. Now, you may think, well, these are older people. As we get older, we do change. And I'm sure my husband's in the audience, he'll probably say, I'm not the person he married 15 years ago. This is more so than that, much more so than that. Of course, we have some changes, but we're looking for a full personality change. Other behaviours are things such as hoarding or checking, complex behaviours that occur. And we also get a change in eating behaviour. And this is where people start cramming sweet foods, binging. This becomes very problematic with people with bulbar symptoms, which are the changes in the mouth, because you can get choking, a hazard of choking. And a final other symptom is one of apathy or inertia. And this is when people just don't generate anything. They become very passive. No generation of idea or even speech. Okay, so combined with this behaviour change is something we call executive dysfunction. So this is a cognitive thing. This is a change in people's thinking. Now, our executive functions are all those higher order cognitive abilities that we use all the time in order to function properly. In order to achieve any goal in our day, we're using our executive functions. Now, I always use this analogy. I'm sure my students will be bored of this one, but I always use the cooking analogy because I think it fits it so well. So you imagine that you've woken up on a Sunday morning, and after the fog has cleared from your mind, you realise that you've invited your in-laws, who are also here in the audience, I notice, I have to be careful, to dinner. And you say, don't worry, I've planned this out. I've got a full menu planned. We're going to have a lovely turkey dinner, beautiful Sunday, lovely dinner. So you go downstairs and you think, oh, the turkey's still in the freezer. There's no way I'm going to be able to defrost it in time, and it's far too big to fit in the microwave. What am I going to do? So immediate disaster. So, okay, I planned, but something went wrong. I have to now problem solve. What am I going to do? Okay, search through the freezer. There must be something that I can get into the microwave to defrost. Fish, marvellous. I can see lovely bit of salmon there. That will do. Defrost it quickly. And then I have to organise myself to make sure that the dinner is there on time. So 3 o'clock, when my in-laws walk through the door, you've got a lovely spread in front of you. I have to make sure the potatoes are boiled at the right time. I have to make the salad at the right time. And in fact, what it involves, and everyone knows who does any cooking, is a lot of multitasking, doing several things at once. So you can imagine in people with a dementia syndrome, where these functions are affected, things go to pot. They really are unable to achieve their goals. And I say, as I say, the cooking analogy, because it's often a symptom reported by carers. Oh, they're not able to make the dinner anymore. There's something going on because they were a wonderful cook before. So other symptoms that you get combined with this may be, for example, a loss of insight. So there's not an awareness that there's been those changes, and that's quite an important symptom of frontotemporal dementia. A poor social understanding, as we talked about, and this initiation of speech and action. So this is actually an email I got sent by a carer to describe what had happened. So I'll read it out to you so you don't have to read it. My own GP has told me that MND just affects the limbs and not the brain functions. I have to disagree, as in 1 year of my late husband's life, I saw the change of a caring, conscientious family man into an uncaring, unsympathetic, confused and aggressive person that none of his family or friends recognised. A professional man that did the most bizarre things that were totally out of character. Even colleagues had noticed that he'd gone from a very efficient team leader to a couldn't-care-less attitude, even before he was diagnosed. He became unrecognisable like a stranger, even though we'd been married for 22 years. One of the important points here, it says here, the professionals he saw did not in their appointments see the man he had become. And that's because when people come to our clinic, we just get a little snapshot how people are. So maybe they're talking a lot, maybe they're making a lot of jokes. Maybe you think, well, they're quite friendly, quite lively, but you didn't know how they were before. And what you're looking for is a change in behaviour. Okay, so let's go back to our little slide here. Now, the observant amongst you, including my children, would have noticed that I've got 50% here of patients with MND who've got this motor problem, 15% here. What's happened to the rest of them? It should all equal 100%, shouldn't it? So, there is another group of people, and it's here. And this is what our researchers mostly focus on. The additional 35% of people. And these people do not have a dementia syndrome, but they do have problems with their cognition and their behaviour. How do we know this? It's because we've run a lot of neuropsychological studies. And we've done interviews where we assess their memory, their thinking, done a lot of different tests, and we've all picked up these deficits. And as you can see, we were one of the earliest group, but there are subsequently lots of different other groups around the world picking up the same thing. About another third of people have these changes. And because we get this range of symptoms, people have said, well, they're obviously linked. There must be this spectrum of change, ranging from those only with the motor symptom to the frontal temporal dementia. Now, it wasn't despite the fact that myself and my colleagues, Thomas back in the audience, for example, have been saying for many years that these changes did occur in MND, I don't think it was really until this finding that we were really noticed. And this is when they found a gene. They found a gene to link the two. And this was a mutation. I'm not going to read this all out, but the most important thing is this term, C9orf72. And this mutation is found in a considerable number of MND patients. Well, it's probably about 30 or 40% of familial MND, that is where it runs in a family, maybe 10% of other MND cases. It was found also in a large number of people with familial FTD, about a quarter of those. And because we found this genetic link between the two disorders, it really validated and confirmed our findings over many years. Okay, I'm going to now tell you about the types of cognitive studies that we've done and that many of the researchers here have done, looking at these changes, mostly in that group of 35% of people who have these specific cognitive and behaviour changes. Now, the most common tests that we use and that have found a deficit almost on every study is a test called letter fluency. And this is a simple test. You give someone a letter of the alphabet and they have to just say or write as many words as they can beginning with that letter. Now, I usually bring someone up from the audience, and they're all really looking worried here, the students, but I'm not going to do it. I've got a little video, I hope.
Person, pink, P, parabola, parameter, purple, people, paper, pose, pony, paid.
Okay, we'll stop there before she struggles too much. And that is a passing intern, Danit. Thank you very much, Danit, who was very kindly, when I shoved a camera in her face, was able to generate some words for me. I do have another one.
Song, sing, shock, shop.
I'll stop there. I think Denise is in the audience. I don't want to embarrass her too much. And thank you, Denise. So Denise actually did that task really well, because what she did was actually she used a number of strategies that she generated. So she used semantic strategies. So I said words beginning with S, and she went sun, sea, sand. She went shoe, sole, sock. So she's generating words that have some association with each other. And then when that dried out, she started using the sound of the word. So she went shock, shot. And it is that generation of strategy and that switching between strategies that makes it a very heavily executive task. It's a task that you need a lot of attention and you have to really keep on going. Okay, am I going to get back to my presentation, please? Okay, can't see anything here. There we are. Okay. So, for example, this is with a motor neurone disease. So this is a written test we've used here. You can use spoken or written. And here we have a healthy control with the words beginning with S. And this is our MND patient, able to generate words, but not as many. But you may think, okay, well, the problem is, obviously, some people have problems moving their hands. And so they may just be slow at writing. So we take that into account by incorporating a little control condition. So after I get them to write those words, in let's say 5 minutes, I then say, well, can you just copy them out and I'll time how fast it takes you just to write it. And so I've got a measure of their motor speed. And so then I use this thing called a verbal fluency index, and I say the time allowed for the test, let's say the 5 minutes, minus how long it took them to just copy the words, and I divide that by the number of words, and you're left with an average time taken to think of each word. How long were they sitting there generating words? And using this, you can see on one of our longer tests, that's a control. They took about 5 seconds. The MND patients took about 10 seconds. And someone with the full-blown dementia syndrome, maybe 20 seconds or so to generate a word, to think of a new word. They really are producing maybe 3 or 4 words for a minute, and that's all. So, those were one of the earlier studies that we did. And this is when, as I say, we really thought we were battling against this notion that MND was just a disease of the motor system. And so when I joined Nigel Lee and Laura Goldstein over at the Institute of Psychiatry, one of the big challenges was let's scan people, let's use brain imaging, which was really developing at the time. And so we used a method of imaging called PET. And this is a method where you give someone an injection with radioactive labelled water, and you watch that zoom round the brain whilst they're doing a particular task. So the task I was going to use, obviously, was letter fluency. So people are in the scanner, and you're looking at how active or how much blood flow is racing through their brains. So this is a comparison of those MND patients with a letter fluency problem and controls. And what these black areas are showing are areas where they're not activating their brains as well as controls. So this was really one of the first demonstrations that there was a frontotemporal problem in some people with MND. These are patients who don't have a letter fluency problem, and there's hardly any regions where there's a significant difference between them and controls. They're activating their brain as well as controls. So it's showing, yes, in some patients, it is just a motor syndrome. So later on, we followed this up with MRI. And I'm sure many people know about MRI. It's a very noisy method of scanning, but it doesn't involve giving any radioactive, horrible chemicals, so it's a little bit better. And it also has much better resolution. Now, when you're in a scanner, as I say, it's very noisy, and getting people to do these tasks, such as letter fluency and things like that, is really hard, because it's very noisy and they can't move. So how are they going to speak? So what we do is we take the images only for 2 seconds, and then we have a quiet period in between which you can present them with a stimulus, they can say a word, and then we scan. Present them with the stimulus, say a word, and then they scan. And using this method, we get very nice activation, This is a bird's eye view. Imagine going from the top of the head, so that's where the front of the head is and the eyes. So this is the left frontal lobe, the left dorsolateral prefrontal cortex. And we know that it activates that area. And this is a comparison between our MND patients and controls, and we're showing a reduction in this area, a reduction in activation, in the blood flowing in our MND patients. And remember, these are not people with dementia. They just have these specific cognitive problems. Now, more recently, we've progressed with that. We've progressed to look at other types of executive functions. It's not only fluency, there are other executive deficits that are involved. So this is a student that's already completed his PhD, who's now in clinical training, Lewis Pettit, and he wanted to know, well, those fluency problems that you're seeing, is it because people are just slowed in their thinking? Maybe they just are slow at generating those words. Now, this slowed processing is actually a feature of other neurodegenerative conditions, other motor conditions that we find. So it was a reasonable hypothesis. So he compared speed of processing to an executive test. And the one that we used was a multitasking or dual task paradigm. So the two tasks he combined were these. Now, this is a processing speed test developed by Ian Deary's group. And what happens here, you see a stimulus. So this flashes up on the screen, and you can see one arm is longer, one arm is shorter. And all you have to do is to say which one is longer. Okay, very easy. So a mask appears, and you say, okay, which one was it? Was it the right or left? The problem is that what we do is we vary how long this is on the screen for. So sometimes it flashes up really, really fast. Okay, and we want to know whether our patients can pick it up at that very fast speed. So it's a very good test to use with people with motor neurone disease because they don't have to react in terms, it's not looking at how fast they press a button, they just have to say, did I see it or not? Was it left or right? So we did that task with them, but we added an additional task. On top of that, we get them to remember some numbers. So they remember the numbers, they do that task at the same time, it's quite demanding, and then we see how they do. And what Lewis found was that on our inspection time task, the processing speed task, we didn't find any differences between our patients and our controls. So they can process information presented very, very quickly. It's not a processing speed problem. However, when you combine it with a second task, that's when the errors begin. So you overload them between two tasks, they're switching their attention, they start to make errors. And that's, as I say, a part of this executive dysfunction. Now, when I came to Edinburgh, I had the pleasure of meeting Mark Bastin, who's an expert in a particular type of imaging of MRI. And this imaging is called diffusion tensor imaging. And what it does is it looks at the big tracts, the long fibres that run down the brain. So these are all the connections, the long fibres. And so we imaged some MND patients, and what we found, not surprisingly, was this is the motor tract, really, the corticospinal tract, and we had problems there in the integrity of that tract. But we also found changes in these two, the cingulum and the uncinate, both of which led to the frontal lobes. So it looks like we were looking at some kind of disconnection problem, disconnecting the frontal lobes to, in particular, the temporal lobes here. So what Lewis did, he got his task and he correlated it. He saw whether there was a relation between those changes in the brain and his dual task and his processing speed, etc. And what he found was, yes, there was a relationship between the dual doing two things at once and how damaged the white matter was in this particular area, regions going into the dorsolateral prefrontal cortex. And he found different areas which were related to fluency. So what it was showing was there were different tracts related to these different types of executive function. Okay. I'm going to move now on to another area. I'm going to talk now more about the behaviour change that we see in these patients. And in particular, I'm going to talk about apathy. Apathy is a very prominent symptom in MND. I think the most prominent by far of the behaviour problems. In a lot of studies, in about 40% of people, we get this apathy. This is Ratko Radakovic, who's over there in the front row. And as you can see, this is the type of personality you need to study apathy, particularly unapathetic. This is him, I think, in Taterland or something, is it? One of the MND meetings. Now, when Ratko joined me, he said he wanted to make a new scale, a new apathy scale. So it's quite difficult to measure apathy, particularly in people with motor problems, because most of the questions you ask are things like, well, are you doing things? Are you going out? Well, of course you're not going out because you've got motor symptoms, you're more disabled. And so we designed a questionnaire which didn't ask those types of questions, asked different questions. And in particular, we were interested in 3 types of apathy. You can be apathetic for a number of reasons. There was the executive apathy. This is the, well, I can't seem to finish things, and maybe I'm distracted, so I'm just not getting through it. I can't seem to problem solve my way through things, and that's why nothing's getting done. That's why I'm not thinking of anything new. There is the initiation apathy. This is, I can't think of any new ideas. I can't think of things I want to do. Okay, can't generate new idea. And the emotional apathy. This is that I don't care. I'm not interested. I don't care. Now, the emotional apathy is different from depression, which you do find in some people with MND, because in depression, what you get is negative thinking, very much thinking which is very negative. Here, we have indifference. It's very neutral. So Ratko did some lovely work, just finishing his PhD now, and looked at this in people with MND. And the problem we saw, we didn't find any problem actually with the executive, which I was quite surprised with, but the one he saw was initiation. That's the problem that people are having. They're not generating ideas. Also, he found actually that our MND patients were a little less emotionally apathetic than our controls. So that means they do care. They were feeling things. But it was simply this not generating idea. Now, this might be, we thought, well, maybe this is a feature of neurodegenerative disease, any neurodegenerative disease. So we had to compare it to other disease groups. And the ones we compared it to were Alzheimer's and Parkinson's disease. And you get a different profile in the diseases. So with Alzheimer's disease, you get impairment across all types of apathy. With Parkinson's, you get executive and initiation, and the different profile with our ALS. So this appeared to be something specific to MND patients. This is not just a feature of having a neurodegenerative disease. What about these other symptoms that I described? These odd ones here, the behavioural disinhibition, the loss of sympathy, empathy. Now, this kind of behaviour is pretty difficult to research. You have to look at what you're talking about here. But we do see changes. This is some work by Marwa Elamin, and she came over from Ola Hardingman's group from Ireland to work with us. And so she looked at some behavioural interviews that we had on 137 patients. And she found that around 42% had one type of behavioural abnormality. And what are we seeing here? Well, we are seeing this socially inappropriate behaviour, offensive behaviour to family, friends, strangers, even the police. People are rude, very blunt, sharp, hostile. People are being over-familiar with friends, strangers, for example, walking around the house naked. People are laughing or making crude jokes. And they're showing this impulsive decision-making. They're maybe giving out their bank or credit card details over the phone to con men. So they're becoming actually quite vulnerable. And they're not responding to social cues, walking away mid-conversation. In terms of the loss of sympathy, we have this loss of understanding for other people's suffering. So, for example, we have a reduced understanding of the extra work that the carer has to do. There's a lack of eye contact, they become colder, standoffish, and they're avoiding social contact. Okay, so we've done a few studies which try to look into this in more detail, but as I say, it's quite a difficult thing to research. And in particular, inappropriate behaviour. What is appropriate in behaviour in one situation may not be appropriate in another. I've got some examples for you here, and this is just an example. This is a lovely picture of my handsome husband, Michael. And as you see, Michael is sporting a beautiful blue Mohican. Now, as my kids will tell you, and anyone that knows him, this is actually normal behaviour for my husband. So when he came down with the blue Mohican, my son went, nice. And, and my daughter didn't bat an eyelid. There were some comments of lucky gonk, I think, and troll, but apart from that, nothing. We know this is Michael, this is how he is, and it's perfectly normal for him. This is an artist's impression of me in my Anne Rowling clinic where I work, talking to someone pretending to be a patient here. And as you can see, Asad has kindly given me an artist's impression of a strange haircut. Now, if this was the case, and I did wear this haircut into the clinic, not only would I get a few looks, it may be a little bit inappropriate because the whole interaction between me and this person will probably change. They've never met me before. They walk in. All they'll be doing is remembering my haircut. They won't remember the stories I've given them or the pictures I've given them to remember. They'll just say, oh, that lady with the pink strange hair. So possibly not very appropriate. But as you can see, what is appropriate in one situation may not be appropriate in another. Here's another example. When I asked Lewis, the researcher that I told you about earlier, to send me a picture, he sent me this one. Now, as you can see, Lewis here is in a rubber suit. He doesn't come to work like this, but if he did, that may not be appropriate. It is appropriate if you see what he does in his spare time. Whilst he's not a psychologist, he's a surfer. Okay. With behaviour, context matters. So that's one important thing to consider, that when we look at how we are behaving appropriately, we judge the context of our actions. Is it appropriate in that particular situation? Another process that we need to do, which is important in social behaviour, is something called theory of mind. This is our ability to understand what someone else is thinking. Okay? So unfortunately, we don't have these flip-top heads that we can look in. We have to judge what people are thinking by maybe their eye gaze, how they're looking at you, are they smiling, are they paying attention? And from that we infer, oh yes, they're listening to what I have to say, for example. So it's the ability to infer the mental state, thoughts, feelings, desires of another person, and to understand that their view is different from your own view. Okay, so these are the processes that we can investigate in people with motor neurone disease. We know that these processes are particularly impaired in people with this frontotemporal dementia, which may occur without MND. So this is a study done by a student of ours who came a while ago, Marco Cavallo, together with Sarah McPherson, who's a senior lecturer here. And so he was looking at whether people with MND have a specific problem in processing social information. So he looked at these cartoons. Now in these cartoons, this is a non-social because it's only got one person on it, and you can see someone here is changing a light bulb. And what you have to do is select the end of the cartoon. And hopefully the obvious sequence is that he's changing the light bulb because he wants to sit down to read. This is a social situation. Here a person walks onto a train, there's someone's bag on it, and the person looks at the man, points to the bag, and if you're feeling socially intact there, you hope that the end of that story is that he's going to sit down, not that he then brings the trolley, which I quite liked at the end. So, what we found with our MND patients, they have a particular problem in processing this information, but they were fine on this. So here we have a social context that they have a problem with. Okay, that's quite a complicated task. So what Sarah and I did was look at a much simpler task. We got it down to a very easy task. And this is with a student who came to us, Alessandra Gerardi, for her MSc. Now in this task, in fact, what you see on the first screen is you don't see the face, you just see 4 objects. And at the beginning, you just say, well, which one is your favourite? You can say, okay, well, I like cats. My favourite is a cat. In the second screen, you see a person's smiley face. And you can see, and the question is, which picture does the face like now? And if you're feeling socially intact, you'll say, okay, well, the face is smiling and looking at the dog. So I am going to infer that that face likes the dog. What you find is our MND patients, not all of them, just some of them, aren't able to do this task. What they do, more so, is they'll choose the cat more often. They choose their own favourite. So they're not able to shift their attention from what they like to what someone else likes. When we change the wording very simply to what is the face looking at, so here we see the bananas, the MND patients are fine on it. So they can process the stimuli and even the words, but it is that inference of another people's thoughts that we believe is affecting their judgment. Dina Vanderhurst, who undertook a PhD with myself and my colleague Thomas Back, and she tried to divide this even further. And what she looked at was 2 components. What is the picture thinking of, and what does the picture love? So this is more a cognitive component, and this has emotion in it, the processing of emotion. And what you find is our MND patients can't do either as well, but in particular, they have a problem with the emotions, the processing of emotions. And quite a lot of people showed this problem. Okay, this is a test developed by a PhD student, Asad Baksh, who's here looking very energetic, maybe a bit impulsive, jumping next to the Grand Canyon, possibly not the best thing to do. But, and he developed another test to also really try to probe these social behaviours and our understanding of them. So as you can see, got a nice old lady. Mind you, I've got my mother in the audience. Walking along, you can see that her shopping bag splits. And we've got a nice gentleman coming along. He looks at the bag. He looks at the lady. And he walks off. Okay. So what Asad is doing, he's asking people, well, what do you think that the lady was thinking? What was the lady feeling? And was this appropriate behaviour? We would hope that that wouldn't be appropriate behaviour because we're all very polite people, nice people. And the final question he was looking at is whether you would behave in that way, in that situation. And so he's looking for the types of response. Now, so we haven't done this one yet with MND patients, but this is in conjunction with Sarah McPherson and Bonnie Ayung in the department. But he has looked at an older population and also a population with autism. Now, firstly, the older population, he has found some changes. In particular, he found a change in this cognitive theory of mind. People weren't quite as good at saying, well, what is the other person thinking? They were fine on the feeling. What are they feeling? Now, people with autism, we know, have problems processing social information. And so what he's found with those people, so far, this is all preliminary data, is we're finding a change on at least 3 of those components. So what are people thinking? What are people feeling? And this understanding of the social norm. However, when they were asked, would you do that? No, they were able to say, no, I wouldn't. I would behave differently. Okay. So another way of looking at it. Okay, in the last part of this talk, I'm going to now talk to you about an assessment that I've made with a couple of my colleagues. And in particular, we want to know how this, I mean, it's all well and good doing all these huge cognitive studies, but what good does it do to a person with MND? And so, and in fact, most people who are coming to the clinics, we had no idea what their cognitive status was. And there's no way I'm going to put them through 3 hours of testing. This is a screening test that I've developed with my colleague here, Thomas Back. I've chosen the pictures where he looks most international here. So Thomas is probably one of the few people that I know who went to Guam to see the actual patients. It's a specific type of MND they have there. He developed the test with me and also with our nurse specialist, Judy Newton. And Judy has been working with MND for as long as, not even longer than I have. And it was just a chance that she came up to us when we were thinking, oh, we have to do something about and develop a screening test. And Judy said, I want to do it. I've seen so many patients in my clinical practice with these problems. I want to do some research to try and improve the situation. And I think developing a short screen actually went against our nature in a way. I think we were, in a way, putting our other neuropsychology colleagues out of a job by doing it, because not doing, you know, if you can assess someone in 20 minutes, then they don't have to do the full assessment. And what we developed together is this Edinburgh Cognitive and Behaviour ALS screen. So this is a short 20-minute assessment that an MND health professional, so not necessarily a neuropsychologist, can undertake. It's multi-domain, which means it assesses not only executive functions, but we know that in MND there are problems in language, and that's again my colleague Thomas Back, who's a specialist in this area. Fluency, and we also wanted to look at other functions, things such as memory, visuospatial functions, things that may not necessarily be affected in MND, but they could occur, for example, with Alzheimer's disease, which we may be seeing sometimes. It's designed for people with a physical disability, and it includes a behaviour interview of the carer, the informant, to tell us whether there's been any of these personality changes. Very briefly, it assesses language, so you've got these, it's quite a nice little test to do. You show people pictures and they just tell us what things are. It assesses comprehension, so you questions such as something with webbed feet, and hopefully you'll be looking at the swan there. There's some spelling, because we know that some MND patients have a spelling difficulty. There's good old fluency in a couple of variations. There's a whole range of executive functions, so including saying numbers backwards, alternation. And there's also the good old social cognition test, this face processing task. For memory, we have a little story that we read to people of a Mr. Douglas Watt. And then we have some visuospatial tests. Can they, for example, process things visually, counting dots, counting cubes, number processing there, and spatial location. So here's just some data from that, which Judy's putting together. And we see that in our Scottish sample, so this is of, I think, 78 here, the most prominent deficit are in the ones we predicted would be impaired executive, language, and fluency here, less so on the memory and visuospatial. And the behaviour change is also there. We find people with the apathy, but the whole range of other symptoms are there in our MND patients. 51% of our patients had behaviour change here. Now, Elaine Niven, who I think is also here, came to us as a postdoc, and it's all well and good that you make these tests and go, here we go, there's a test that you can use in the clinic, but unfortunately you have to show that it's as good as you can get to a big full neuropsych interview. So poor Elaine went through a big study, and well done for the 40 MND patients that did this study, where she not only did our little 20-minute test, but these are the whole range of lots of other big neuropsychological tests they also did. So you have to say it's as good as picking up as a deficit here. And what we found, it is pretty good. In fact, just with some conservative measures, 85% sensitive. And we could increase that to 92%. So we are picking up almost everyone that we would have picked up with a full neuropsych battery. So really, it's giving you so much information just from a 20-minute test. The MND community seemed to be quite ready for a new test, and I think it took Thomas and I a bit aback as to how quickly it was taken up and went round the world. And these are the translations that I know of and that I've monitored. So you can see you've got quite a few different languages here that has already been translated, and we only released the test about a couple of years ago. The paper came out now. So it's gone into the major ones. The Germans and Swiss one was probably the most extensive immediately, have already published on it, immediately 200 patients assessed with the German version. But Italian have a similar number of patients, Spanish, Portuguese, etc. We even have North American version with Douglas Watt, got changed into Robert Weber. But these are the most challenging of all, the Japanese and the Chinese. Doing fluency in Japanese and Chinese, I left to my colleague here, Thomas, a linguist between us. But we have managed even a Hebrew version as well. So as I say, it was taken up very quickly by Europe. This is actually the last meeting of the European group over in Dublin. You can see, I think there's, if you like, where's Wally here? But I did spot a couple of our, I think Ratko was there and Laura Stevenson I saw, and Chris over there. And so these are the people that have been, a lot of these people were trained at that meeting to use the ECAS, and then they then submitted to me data from that ECAS, and I then started to analyse it. And what we found across Europe, and these are not demented patients, it was picking up about a third of people who had a cognitive impairment. So that's what I thought would happen. So about a third of the people have got these changes. And the types of impairment we were getting were executive, fluency and language, a little more memory and visuospatial, but it was picking up impairment certainly. This is Tom Booth and Asia Murray, who recently got married, actually. Fabulous pairing of two wonderful statisticians. And I handed them the data and say, do something fancy with your equation modelling, which they have done. What they do is they analyse all my 700 cases, and they see what patterns emerge. And so what groups emerge of people. And what we found a nice big group who were impaired on our test. But in particular, we found a group that separated out because they also had this particularly prominent language presentation, which Thomas went, aha, to. You can also see, well, what's different about these patients? Well, the patients were slightly older in these groups, but interestingly, if you remember when I told you about that strange genetic mutation, that predicted membership of this group, very much so. And so if they had a C9orf72 mutation, even though they didn't have dementia, they were more likely to be in the cognitively impaired group. So here it is, another piece of the puzzle in terms of the spectrum. So those C9orf patients, these are the errors, are more impaired across our tests. What about the behaviour? Is this found in the same people that have the cognitive problems? Well, it doesn't look like it. It looks like they're separating out a little bit. So you get some people who have the cognitive problems and they have behaviour change. And then we have the people with cognitive problems but no behaviour change. So they're just cognitive problems. Maybe they have the fluency or some problem. Then you've got these patients here. They've got no cognitive problem, but they do have a behaviour abnormality. So they look like they're overlapping, but they are distinct also people, separate groups. So this is quite an interesting finding for us. It looks like they're different presentations. Now, because we have this screening test, it means we can do more things, because it's only 20 minutes. And one of the things that we can do is we can assess people longitudinally over time. Because it's only 20 minutes, they'll do it. And even when people are physically disabled, they'll do it. So this is Chris Crockford, who is doing his PhD with us. And this is a study funded by ELSA, together with Orla Hardiman from Ireland and Amar Chalabi from London. And Amar developed this staging system, which is based on the physical problems that people have. And what happens in this staging system is that when onset, when you only have, let's say, one region involved, let's say your hands are involved, you're just at the beginning of the disease process at 0. When 2 regions are involved, you're at 38% of the way through your disease course. 3 regions, you're 61% of the way through your disease course. And when you have problems with your respiration or nutrition, you're about 3/4 of the way through your disease course. So what we want to know is, how does cognition fit in with that? How does it relate to where you are in the disease process? So Chris has done lots of work in developing these parallel versions. You can't do the fluency twice within 3 months because people get better at it. You can't tell them the story about Douglas Swap because they will remember, oh yeah, I remember that story, you're going to ask me about that. So you have to develop new stimuli. And so Chris has done some painstaking work in making 2 more matched tasks. Now, because we can now follow people up, we can now relate our findings in terms of cognitive change to what happens in the brain post-mortem. So these are tissue, brain tissue that was donated to us after death. And our post-mortem MND bank, our tissue bank, is headed here by Professor Colin Smith. And we've got wonderful people such as Tom Gillingwater who look at these brain tissue using very high intensity microscopes. Tara Spire-Jones and also Chris Henstridge do some fantastic work looking in particular at the synapses. Now what these are, this is your neuron, this is your motor neurone. So this is the spine, this is the cord running down. And what you're looking at is the junction between neurons. How do they talk to each other? So the synapse is this point here, the meeting point between 2 neurons. And so what they do is they take sections from the brain post-mortem, and they do this wonderful technique, array tomography, where they can produce these 3D images of how dense these synapses are. If you've got a nice healthy brain, you're going to have lots of synapses. They're all connecting, they're all talking to each other. And if you not have a healthy brain, these are maybe gone. And so here we have the pre and post synapse stained a green and a red, and this is an ALS patient. You can see it's much reduced. But because we have our ECAS, we can relate what happens in life, how they did on our cognitive test, to how they are at the endpoint. So, and this is an example here. This is a control patient. This is how dense the synapses are. Someone with MND who is cognitively normal, and this is taken from the frontal lobes, not the motor system, just in the front, more to do with the executive functions. And this is a person who is impaired on our ECAS, and you can see that their synapses are much reduced. And that's that person, these 2 people there. So we're really now, the first time, we're really looking at, well, what happens in life in cognitive problems, those symptoms, to what happens exactly on a cellular level down in the brain. Okay, I'm going to end up with just talking just very briefly in terms of what difference it makes. And this is what difference it makes to people living with motor neurone disease. So I've told you about all these types of problems that people may have. And what it means for the person is this. So maybe they have difficulties managing their finances or their affairs. Maybe they have difficulties planning for the future. Maybe they have difficulties making decisions over those, or difficulties learning new tasks. Now, all those things is exactly what you need to be doing if you've been given a diagnosis of MND. You want to be sorting out your affairs and your finances. You want to be planning on what's going to happen. You might want to make some choices about your end-of-life care and decisions. And as you become more disabled, you might need to use things such as a feeding tube, or you might need a respiration device. How are you going to learn to use these new things? Or if you have a communication becomes problematic, you might need to use a light writer, an automatic voice. So what happens with these people that have problems, this is where they get stuck, and this is where we can support. So for example, we can support in making decisions. We can give people time. If you've identified that they have a cognitive problem, you don't sit there in the clinic, quickly make the decision with them. You give them very simple information, take home, talk to the carer, discuss, let them try to consider the consequences of the actions. You may think that some devices may not be suitable for someone with, let's say, spelling difficulties. You might not give them an automated light writer where they have to spell out all the words. For people with socially inappropriate behaviour, one of our big things is to educate the carer, to say, well, this is part of the MND. This is not because your relationship is deteriorating, it's simply part of the MND, and it's not that they're being stubborn or anything. So we're trying now to integrate the screening into clinical care. So, for example, within Lothian and through actually now quite a few areas in Scotland, we have the MND care specialists, such as Judy, doing the screening, and a neuropsychologist will supervise that screening. Sometimes the neuropsychologists will do the screening themselves in certain places, such as Glasgow. They've decided to see all the MND patients now, and they'll just use our ECAS to screen. And the MNDA have now just funded us to look at pathways to national screening. So we're going to try and juice this around the country. This is the type of thing that we put into the care notes. So it's just our ECAS scores, and then we say, well, what the problems are, and then we give them some advice on what to use, what kind of strategies that maybe you could use here. So why is this important? Because we can improve healthcare. So we can screen for people as close to diagnosis as possible, because we know these changes are right at the beginning of the disease, and then we can tailor our intervention if they do have those problems. In terms of research, we can also make recommendations, for example, for clinical trials. And this is a very important area, because before, and until now really, they've ignored these cognitive problems because they don't know how to deal with them. But now we're involved with recommendations for the FDA in what should you do, how you should assess for cognition, and what you should do. In particular, people with cognitive change must be incorporated in all trials. But you don't want to be a situation where you have a therapy which slows down the motor symptoms and people progress cognitively, so may go on to dementia. And the most important thing is education. This is the new handbook produced by the MNDA, and it's a very detailed handbook describing the cognitive changes for all healthcare professionals. So we have advice now going into GPs, going into MND teams on this. So I just want to conclude with these real points. So the mind does matter in MND because we know that cognitive change and behaviour change are an integral part of the disease and are found in up to half of people with MND. So what I'd like to happen is that let's identify it quickly, and then let's try and do something about it to improve healthcare. Okay, so I've gone on and on and on. So I'm going to stop now. And I'm going to thank people. I'm not going to name everyone because there's millions of people on there. And so particularly, though, I do want to thank everyone involved with the ECAS, Thomas, Judy, Elaine, Chris, the cognitive team, Ratko, Dina, Lewis, neurology, Siddharthan, Robert Swingler, Richard Davenport, Savanka Powell, George Corey, David Simpson, EMC, Ewan McDonald Centre, Shuna Colville, Laura Stevenson, Denise Cranley, and in particular, I want to thank these people because over the years we have seen so many people with MND and they've all volunteered to come and see us, or we go and see them, and to sit through all our cognitive tasks, etc., or to have the ECAS and their families, and they very, very kindly participate in this work. So I'm going to leave it there. I think I've talked too much.
That was a real model inaugural lecture, I think, full of fascinating information, really valuable, useful information, but delivered in a way that all of us, with all our different backgrounds, I'm sure found completely accessible and interesting. So I know that we've now got a chance to have a reception and help celebrate with Sharon outside. That's the place to perhaps pose some questions individually if you'd like to ask any questions to follow up some of that fascinating material. But in the meantime, I think I'd ask you to join me again to thank Sharon.